So how do you treat hemolytic anemias is an important question. One is you can give RBCs to replenish. Second is whenever the hemolysis is ongoing and bone marrow is compensating with an increased erythropoiesis, you should supplement folate. If you only give RBCs and steroids, that is not enough. Suppose if it is any form of hemolysis. Then comes sickle cell. We had been studying right from our school days sickle cell anemia. You ask even a school kid, 7th class, 8th class, if he is a brilliant kid, he will say autosomal recessive disorder, and it is valine substituted by negatively charged glutamic or glutamic for valine. V for G or G for V? That's right. V for G at the 6th position of the beta chain, as all of you know. Now doctor, let's come to a practically seeing a case of sickle cell anemia. The whole villagers will bring a young boy of about 17 years. He is febrile and he is gasping for breath, and he is a known case of sickle cell anemia. He will have severe body pains. Always remember, earlier also he used to have this kind of episodes. He is a very famous boy in the village for these problems. Three things are dangerous in a sickle cell anemia guy. He should not be dehydrated, he should not go into acidosis, he should not get an infection. These three must be carefully managed. Any infection, acidosis or dehydration worsen the sickling is what need to be remembered. So you are the house surgeon on duty. What will you do? First thing, put oxygen mask. Take care that there is no hypoxia. Start an IV drip. Take care of his dehydration. Get a chest X-ray done. If there is a pneumonia, immediately start antibiotics. That's the only thing that you can do to treat that patient. So doctor, acidosis, hypoxia, fever, dehydration, infection, they all will worsen the sickling process is what need to be basically remembered. Then you have two kinds, sickle cell trait guys. Trait are heterozygous, they are not anemic and they will have a normal life expectancy. And I still can't forget, he is a professor of English in CFL, Central for Institute of English as Foreign Languages. No, he is a professor. He was still writing a beautiful poem that day evening while I was on duty. He writes a very good English poems and literature. Suddenly at around 8:39, he called and he was in, he has gone blind acutely in the ward, unfortunate story. And without we are able to do anything or salvage him, there was an acute vaso-occlusive crisis which has led to a acute mortality. Post-mortality, when autopsy was done, he had a diffuse vaso-occlusive crisis. So that's how sickle cell disease, he was a homozygous guy, but he managed throughout his life. He was a 43-year-old professor of English in CFL. I can never forget that night attending the autopsy. So doctor, when you do autopsy, you will find all that accumulated bilirubin and that contracted spleen. So you will see the what all is described in the book is existent in patients, but it depends on which hospital you are working and what kind of patient you came across. Did you diagnose him at that time? So there are all the multitude of factors which will decide whether you will finally experience what is being discussed in the textbook. That's the reason, what do they say in medicine? Art is long, life is short, with the opportunities fleeting. So every night, every day you are losing a chance of a possible chance of seeing what is discussed in Harrison and Davidson. So take every day opportunity to not miss the hospital. And sickle cell anemia, sickle cell crisis, you can see the typical sickling on the peripheral smear. This is another example, typical sickled erythrocytes in a homozygous individual with sickle cell anemia. This is an autopsy of a contracted spleen, autosplenectomy in case of sickle cell anemia. Since there is a possibility of consanguinity being detected in the history, you need to offer for asymptomatic carriers a genetic counseling. The survival of a sickle cell anemia patient mainly depends on the vaso-occlusive crisis. And vaso-occlusive crisis, if a good number of times patients can't be able to survive. If there are more than 3 crises per year, vaso-occlusive crisis, most often the median age of mortality will be 35 until the guy becomes associate professor. So that's the reason you need to carefully monitor, prevent. What are the 3 buzzwords you will not forget? Fever, infection, dehydration, hypoxia. There are the 4 things which you need to avoid in a patient who is having sickle cell anemia, is what need to be remembered. Now, there will be periods of remission, sometimes there will be painful events, and all these sickle cells will lead to microvasculature obstruction and that lead to development of the vaso-occlusive crisis. Now this is another example of a patient who has a combination of 2 kinds of hemoglobin, both sickle and also hemoglobin C. It's called SC, sickle C disease fundamentally. And in this patient what you find is this target RBCs, they are called as, with a central reddish dot, which is characteristically seen in the case of the hemoglobin C disease. In addition to that, you also find some amount of distortion in the shape towards sickling, which is classical of HBC, S combination of the disease. This is another example of target cells which can also be seen in the case of thalassemia major, as what we have discussed yesterday, the target cells. Okay, doc? Now coming to the clinical features, jaundice, pallor, obviously due to sickle cells undergo hemolysis and that lead to it. Very important thing is, all that released bilirubin can form bilirubinate stones leading to gallstones. They become transfusion dependent. Ultimately they will have a cardiac decompensation leading to the development of the cardiac failure. In some patients of sickle cell anemia, if there is a parvovirus B19 infection, instead of anemia you will come across pancytopenia. All the 3 cell lines affected. That is called aplastic crisis in a patient of sickle cell anemia, but usually it is a transient phenomena where they recover within 7 to 10 days. So how do you recognize a painful vaso-occlusive crisis? It can present in the form of a infarcted bone leading to a severe bone pain. Tibia, humerus, femur are the very common bones which are affected by this painful vaso-occlusive crisis involving the bone. Even that is also a transient phenomena of about 2 to 7 days. Then another important complication in the sickle cell patients is called hand-foot syndrome, where the fingers typically become inflamed with the painful swelling of the dorsa of the hands and feet will occur, and there is an avascular necrosis of the metacarpal and metatarsal bones, which is called sickle dactylitis, otherwise called hand-foot syndrome, is what need to be remembered. Then you can have multiple pulmonary infarctions which can occur, which can lead to acute chest syndrome, where they will have chest pain, respiratory distress, etc., etc. Now this is a classical radiograph of the bone. It's called bone within the bone appearance. When there are multiple infarctions of the long bones, there will be sclerosis of the bone due to the infarct, and that gives what is called bone within the bone appearance, which is classical in the case of the sickle cell anemia, is what need to be remembered. There can be repeated splenic infarctions with the orthosplenectomy by the time the child reaches about 4 years of age. A vascular necrosis of the femur, of the hip. One of the causes is sickle cell anemia. What are the other causes, doctor? Those who receive corticosteroid therapy. A vascular necrosis is very common. There is a big list. We will take it up in orthopedics anyway. Then there can be a priapism because of the vasoocclusion involving the vasa vasorum, leading to the development of painful erection. And for this we can give hydralazine and nifedipine as a part of the treatment. And there can be sometimes sustained priapism more than 3 hours, but if it is there, then that becomes a medical emergency. There can be strokes, as I told you. There can be sudden retinal infarct, which can lead to sudden onset of blindness in a patient of sickle cell anemia. Then what are the kidney manifestations you will remember in sickle cell anemia? You know, if you take the kidney has a cortex, kidney has a medulla. Between the two, the medulla is having a sluggish blood flow, hence highly vulnerable to ischemic injury. When there is a vasoocclusion, increased vascular flow resistance to the blood flow to the kidney, that lead to the tubule suffer from ischemic necrosis, and that can lead to development of renal papillary necrosis along with hematuria. You remember what are the other causes of renal papillary necrosis, doctor, which we studied in nephrology, which we have already forgotten? With one void of micturition, all what is learnt about nephrology is into the dustbin. No, doctor. Revision, partially revision. Second is, keep seeing cases. If you know this much knowledge also, it will, if you see 4 or 5 patients with the help of that knowledge, it will grow. If you acquire this much knowledge, if you have not applied for long time on any patient, it will narrow down. That is a law of contraction expansion in medical studies.